This is Rick, an 88-year-old man who is on hospice after his 6-year battle with colon cancer. Recently, Rick has been experiencing a great deal of pain and cannot get comfortable or any sleep because of it. The doctor is going to come in today and discuss with Rick and his family the benefits that round-the-clock morphine regimen could have for him. Hey Rick, I understand you haven't been feeling too well lately. We're going to see what we can do for you today. Can you tell me what's been going on with Rick?
Yeah, of course. So Rick has just looked so uncomfortable and has been so uncomfortable these past few days. Every position we try to change him into to get comfortable, he just grimaces and moans. He just is in so much pain, and we can't seem to get him comfortable no matter what.
Okay, well, I'm going to go ahead and assess Rick and see what I think the next step we can do for him will be.
Okay, sounds good.
NCP guidelines have specific criteria for the interdisciplinary team to follow and focus primarily on palliative and hospice care. The first and foremost is to assess for signs and symptoms that the patient is nearing death. We know that Rick is already in hospice and likely transitioning into his last stage before death. So the guidelines for treatment prior to death, the criteria states to involve the patient and family with a plan and to evaluate the best care setting for the patient, which is why Rick is at home with his family. The criteria also states to ensure access to medications that may be needed, which, as you will hear, is going to be a morphine regimen for Rick. Okay, I assessed Rick, and unfortunately, I do believe he is transitioning into his last stage of life. My best recommendation for Rick and his treatment at this point is to try a morphine regimen for him. Morphine will help ease his pain, breathing, and allow him to sleep better, which will overall just make him more comfortable.
Okay, whatever will help him. What should we expect after giving him the morphine?
At first, the morphine can cause a sedative effect, but this is expected and nothing to be alarmed of. After a couple days, usually, you will see Rick feel more at ease and able to find some comfort. There should be no more grimacing and moaning. The prescription that I will give will be a slow-released morphine, and then that will be scheduled round the clock, and then a PRN morphine, which means given as needed for any breakthrough pain that may occur with him in between those scheduled times.
That sounds like a lot of morphine to give. Are you sure that's not too much?
Yes, patients at this stage of life are typically in a tremendous amount of pain. As you described Rick's behaviors to me before, and from what I assessed with him, he is dealing with a lot of pain and discomfort. I personally believe that this morphine regimen will benefit him and his comfort immensely. In this article I found, it says that morphine is commonly used in hospice facilities. And according to the World Health Organization, it has actually been endorsed as a gold standard for opioids and is first-line treatment with severe pain. Because morphine has a short half-life, it can be titrated very quickly depending on the patient's response. So if you feel like the patient is not getting enough of the morphine, you can titrate up. And if you feel as though the patient has been too much, if their respirations are very low or they're very hard to arouse and awaken, you can always titrate the morphine down. It has no ceiling effect and is only limited by the patient reaction. So monitoring the patient is very important.
Okay, we'll try the morphine regimen and see how it goes.
Hey guys, hey Rick, how's that morphine regimen been going?
So Rick has just looked so much more comfortable in bed, and he has not been moaning or grimacing anymore. He has also been sleeping, which is great for him. This morphine has helped him so much, and he hasn't had too many breakthrough doses as well. Thank you so much.
Of course. I'm so glad it's been working for you. I'm glad you're feeling better, Rick. Some people feel as though morphine might do more harm to the patient than good. They are afraid that it will ease the patient into a faster death or that the patient will become addicted to the medication. Some doctors have even stated that they are afraid of giving too much morphine and end up killing the patient rather than comforting them. To this, I think we need to educate family members involved and medical staff. When a patient is nearing their end of life, we want them to be as comfortable as possible, and morphine is a great option for that. Personally, I believe the risk of the patient developing a dependence or addiction to morphine does not outweigh the huge benefit of comfort that it can bring to that patient. Also, educating medical staff on the quick titration due to morphine's short half-life will be beneficial for them feeling more comfortable about giving it. This can be done due to correct a dose since the amount of morphine is only limited from a patient's response. There is no cap amount of morphine that you can give, which is a great thing because if the patient is on it for any certain amount of time, they can always find relief because as long as they react fine, you can give them more. Education on morphine and its actual mechanism of action will help change people's perception about the medication and medical staff and family members' willingness to actually try it in end-of-life care.